Why don't we go ahead and call this meeting to order? If you're able, please stand and join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. Let's see. Who is there to call our roll?
We have Cheryl Renaud here. I know you can't see her, but she is here in the room.
I'm here.
Hi, Cheryl. Thank you for being there. Please call our roll.
Okay. Director Yee?
Can you see?
Present.
Director Stewart?
Present.
Director Wallace?
Present.
Director Epen?
Present.
Director Nicholson?
Present.
Good. Thank you. And who else is there in the room with you, Cheryl? I see
Kimberly Hart?
Uh-huh.
Larry Labossiere? Chris Henry? Sri Vodou, and Cheryl Renaud.
Okay, very good. Thank you very much. Well, welcome to the December 14, 2022 regular meeting of the Washington Township Healthcare District Board of Directors to continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by the SARS-CoV-2 virus. The Brown Act allows a local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Healthcare Services Public Health Department COVID-19 website at www.covid-19.acgov.org. I ask for a motion that the board make the finding required by section 54953E3B2 of the Government Code that quote, state or local officials continue to impose or recommend measures to promote social distancing.
Madam President, I make the motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Thank you, Dr. Nicholson. Is there a second?
Second.
Thank you, Dr. Stewart. Roll call, please.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Epen?
Aye.
Director Nicholson?
Aye.
Very good, thank you. Public notice for this meeting, including dial-in information, has been posted appropriately in our website. Tonight's meeting will be conducted by Zoom, and I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting, and it will be posted on our website for future viewing. All right, next on our agenda is the consideration of resolution number 1248, acknowledging the appointment of Jacob Epen, Bernard Stewart, and Michael Wallace as directors of Washington Township Healthcare District. We have a motion on resolution number 1248, please.
Yes, Madam President, it's my pleasure to move that the Board of Directors approve resolution number 1248, acknowledging the appointment of Jacob Epen, Bernard Stewart, and Michael Wallace as directors of Washington Township Healthcare District.
Very good. Is there a second?
Second.
Thank you very much, Dr. Epen. Roll call, please.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Epen?
Aye.
Director Nicholson?
Aye.
Very good. Thank you. Thank you very much. Next up is the oath of office. Kimberly, do we have our judge on?
Sri, is Judge Thomas Nixon on?
I am. Can you
Oh,
hear me?
yay. Oh, there you are. I see your phone. Okay.
Okay,
I'm
I will.
so sorry.
Let me do an
running crazy
introduction.
Trying to get this thing to work properly. So, but I'm ready when you are.
Okay, Judge, let me just do a quick introduction of you. So hold on, let me just say, Judge Thomas Nixon is the supervising judge for the Superior Court of California, County of Alameda County's Family Law Division. Judge Nixon was appointed to the Superior Court in 2015 by Governor Jerry Brown and has served as a commissioner at the Alameda County Superior Court since 2002. He was an attorney in private practice from 1998 to 2002, a partner at Quaresma, Benyay, Hall & Connick, O'Hara, and Nixon from 1989 to 1998, and an associate there from 1984 to 1989. Judge Nixon earned a Juris Doctor degree from the Santa Clara University School of Law and a Bachelor of Science degree from San Jose State University. So we'll turn it over to you to do the oath of office.
And the supervising judge of the East County Hall of Justice. So I finally got out of family law.
Very good. Thanks for that correction.
No problem. I'm ready whenever your wonderful group is.
Okay, I believe Dr. Eben is first up.
Hello, Dr. Epen.
Hello. Listen,
If you would do me a favor and raise your right hand to be sworn. Repeat after me, sir. I, Jacob Epen,
I, Jacob Epen,
solemnly swear or affirm
solemnly swear or affirm
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies, foreign and domestic,
against all enemies, foreign and domestic,
that I will bear true faith and allegiance
that I will bear the true faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully
and that I will well and faithfully
discharge the duties upon which I am about to enter.
discharge the duties upon which I'm about to enter.
Congratulations.
Yay. Very good. And then next, Dr. Stewart.
Dr. Stewart?
I'm here.
All right. Will you do me a favor and raise your right hand to be sworn, sir?
Ready.
Excellent. Again, repeat after me. I, Bernard L. Stewart,
I, Bernard L. Stewart,
solemnly swear or affirm
solemnly swear or affirm
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California
and the State of California
against all enemies, foreign and domestic,
against all enemies, foreign or domestic,
that I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation or
Without-
purpose of evasion,
without any mental reservation or purpose of evasion,
and that I will well and faithfully discharge
and that I will well and faithfully discharge
the duties upon which I am about to enter.
the duties upon which I am about to enter.
Congratulations, Dr. Stewart.
Yay.
Thank you.
And last but not least, Michael Wallace.
Let's drag in Mr. Wallace.
Hey. Hello, Judge.
How are you, Mike?
I'm good. I'm good. Good to see you.
You already got that hand up, so we're good to go.
That's
Repeat
it.
after me. Do you want to swear or affirm?
I think I'll just swear.
That sounds good to me. I, Michael J. Wallace,
I, Michael J. Wallace, solemnly swear
that I will support and defend the Constitution
that I will support and defend the Constitution
of the United States.
of the United
Hello?
States.
Did I
Yes.
lose you?
Yes. Of the United States
And the Constitution of the State of California
and the Constitution of the State of California
against all enemies,
against all enemies,
foreign and domestic,
foreign and domestic,
that I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely that I take this obligation freely
without any mental reservation, without
Without
any
any-
mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully discharge
and that I will well and faithfully discharge
the duties upon which I am about to enter.
the duties upon which I am about to enter.
Well, that was harder than it seems, but congratulations.
Yeah, thank you. Thank you.
Oh, very good.
Thank you very much, Judge.
Thank you, Judge.
Thank you.
And congratulations, Jacob.
I am absolutely delighted to do this. And I sometime next week, make sure I sign every oaths.
Okay, we got
Take
maybe
care, everyone.
every fifth word, but thank you. Good night.
I'm sorry. Take care, everyone. I'll see you next week.
Okay, thank you.
Bye.
Well, congratulations, Dr. Epen and Dr. Stewart and Mike. We have a united board and that's committed to serving the healthcare needs of our district. I look forward to what we can accomplish together. Well, next on our agenda is the election of officers. December, full of traditions, and our tradition in the healthcare district is the election of officers. And it would be my pleasure to entertain a motion.
Yes, Madam President, it is my pleasure to move that the Board of Directors elect the following slate of officers. For President, Bernard L. Stewart. For First Vice President, Michael J. Wallace. For Second Vice President, William F. Nicholson. For Treasurer, Jacob Epen. And for Secretary, Jeannie Yee.
Thank you, Dr. Nicholson. Is there a second?
Second,
Thank you, Mike. Roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
aye.
Director Epen,
Aye.
Director Nicholson.
Aye.
Very good. So that passes. Well, may I say what a privilege it is to serve with my fellow board members. You're all men of integrity and a firm commitment to do what's best for the residents of our district. I thank you for your support this past year, and I happily hand the virtual gavel over to very capable hands of Dr. Stewart.
Thank you very much, Jeannie.
You're welcome.
My first order of business would be to thank Jeannie for a wonderful year as president of the board. This was Jeannie's first shot at being president of the board, and I find no fault.
Oh, you're gracious.
It's very true. She was wonderful and very, very easy to get along with and helpful, and worked very hard and diligently at that position. Personally, I thank her a lot for what she did. Very, very well done, Jeannie.
Very kind. Thank you. You all are a great team to be a part of.
So then we move on to our next agenda item, which is communications. Members of the public are invited to speak during oral communications when prompted. Please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who wish to speak at this meeting? Seeing none. Are there any written communications?
There are no written communications.
Thank you very much. Then we'll move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does any board member want to remove an agenda item from the consent calendar? Seeing none. Does any member of the public want to remove an agenda item from the consent calendar? Or hearing none. May I have a motion to approve the consent calendar items A through C?
Yes, Mr. President, I move that the Board of Directors approve the consent calendar items A through C.
Cheryl, if you would take the roll.
I'll second that.
I'm sorry, we need a second. Thank you, Jeannie. See, I told you she was good. At any rate, okay, Cheryl, if you would call the roll on that action item.
Yes, Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Epen,
Aye.
Director Nicholson.
Aye.
Thank you very much. That motion passes. We'll now move to the presentation area of our agenda tonight. Kimberly, if you could introduce our people doing that, please.
Yes, thank you. It's my pleasure to introduce Dr. Eldon Eichbaum. He is a neurosurgeon and co-director of Washington Hospital Spine Program. An honors graduate of the University of California, San Francisco, he completed his fellowship in complex and reconstruction spinal neurosurgery at the University of New Mexico, Albuquerque. He is board certified by the American Board of Neurological Surgery. He has worked at the Bell Neurosciences Institute of Silicon Valley at Washington Hospital and Washington Township Medical Foundation since 2012. Joining him is Maria Nunes. She, MSN, is the clinical manager and nurse practitioner for Washington Hospital Stroke Program. She is a board-certified family nurse practitioner and has worked at Washington Hospital for 22 years, working in critical care from 1999 through 2019 and in the neurosciences program since 2019. All right, Dr. Eichbaum, and we'll bring up your presentation.
Great. Well, thanks for having me, and Maria. We really appreciate just to kind of give you a brief presentation about what we're trying to do here at Washington Hospital. As you know, we are dedicated to the district here at Washington Hospital to serve the patients the best that we can. And also even draw from outside the districts if we can, just to demonstrate our excellent care here. So we have decided that we're going to try to get a advanced certification in spine surgery, which Marie will go into more detail later on. But being that I am the co-medical director for this, I'm doing it with Dr. Erasmus, and although he has retired, unfortunately, which made us all very sad, he's been so gracious to stay on and help us to complete this process of obtaining this certification in spine surgery. Next, please. So the medical directors, as I see here, are myself and Dr. Erasmus. And, you know, we are trying to develop, and we have already developed and continue to develop a comprehensive spine program here at Washington Hospital. There are several different coordinators involved as well. Jocelyn Love is on the floor and helps with nursing and patient education. Darcy Alley is in the OR with us to help us with all we need in the operating room. And then Maria Nunez, we kind of stole her from the stroke program to help with our spine program. And you can see the schematic there. It just kind of shows you the patient being in the middle. And of course, the patient is the main object of all of us. And the way they come into our program is typically through, you know, community relations, whether it's referral from their physician or family members or friends. They get placed into our offices and our outpatient clinics. They may be sent over to a physiatrist first, like Dr. Golden, but frequently they come to us, the surgeons. And eventually, if they do require surgery, which is about maybe 20 to 30% of the time, in my practice at least, they're sent to perioperative services, which all of the preoperative evaluation is completed to make sure that they're ready for surgery and prepared for surgery. And once they have their surgery, they tend to go up to 6 West. A while back, they were going to IJR as well, but now it's pretty much basically on 6 West, where we have an excellent staff of nursing staff that know very well how to take care of our patients. They do an excellent job, followed by other professionals such as the physical therapist, the occupational therapist, and they continue. Not only that, there's pharmacists involved that really give a well-rounded treatment to these patients. Once they're also there, in order to get them home, case management is involved, and that's how the circle continues. Next, please. You can see that we are always trying to increase our amount of cases that we are doing. This is just a graph showing how many surgical cases that we have done. You can see that there was a dip during the COVID year, basically, and we've continued to increase since that time. The spine certification is more to look at certain type of spine cases. And so you can see the number here in 2022 of 355 cases. In order to obtain the spine certification, one of the qualifications you require are having, I think, of over 200 cases, which we obviously have over, but there are certain types of cases that you have to have for the spine certification. And it's mainly related to degenerative spinal conditions, as opposed to trauma or infection, whatever have you. And despite the fact that we have this amount of cases, we have to keep up the certain amount of cases required for the spine program to be approved. Next, please. So what really makes up the spine program? We've got a lot of different things. There's a preoperative education that we have that is not only with our office, but there's online videos that are sent to the patients where they can look and kind of see exactly how they'll be treated before and after, kind of what their surgery entails, what they can expect before surgery and after surgery. They can communicate with us via MyChart and email, and educational packets are also sent to people and patients because many do not want to, at least sometimes they don't want to deal with being online. Post-operatively, again, there's education that's sent out and the nursing staff from 6 West calls and follows up with the patients to see how their treatment was on the ward. And I can just tell you from my experience with my patients, I have yet to have one person complain. In fact, they love the care on our ward. During the time that they're being evaluated and treated, we try to maximize their stay so that and minimize any issues of getting into the hospital and going home. So initiation of durable medical equipment is done even before surgery, and depending on the type of insurance, we try to get that all done beforehand so that it's very easy to flow through the operation in terms of coming in, being taken care of in the hospital, and then moving on. So case management is referred to early on. And in order for us to attain this spine certification, we have to see how patients are doing in terms of their outcome. So we have to report the outcome measures, which are called patient-reported outcome measures, or PROMs. We start that preoperatively, and then it's also done post-operatively, immediately after surgery, and in certain months, weeks and months later as well. We also have, again, very dedicated staff to our ward and our patients, and that includes, as you know, nursing coordinators, physical and occupational therapists. Next, please. So what also, another thing that we want to do to keep this spine program at the top, as we feel that it is that there are certain issues we have to look into to make sure that that we basically are as good, if not better, than anywhere else. And several things we look at are outcomes in terms of certain evaluations, such as intraoperative injuries or pulmonary emboli after surgery. And if you look at the last fiscal year, we basically had no intraoperative injuries, and that means a neurological injury that occurs in the surgery, no pulmonary emboli, no DVTs, and 0 falls. Again, all a nice feather in our cap to show that we really have done a great job, which includes everyone involved, whether it's the surgeon, the planners, the nursing staff. We all work together to try and keep this at a very low rate. We've also decreased our hospital stays, again, demonstrating that we have excellent care and patients getting them home. The vast majority of our patients do go home. And if they can't go home due to whatever reasons, if they don't have enough assistance at home, then we do get them to other places, such as nursing homes as needed, nursing facilities. We try to get our patients that require rehabilitation or physical therapy after surgery to our outpatient center, and at least about 50% go there. And the majority of the reason if they don't go there is usually they might not live in the area. Another great feather in our cap here is to show that we have our patient satisfaction score is very high at 87.5, which is well above the national Press-Ganey benchmark of 83.9. Next, please. So our next steps include having a revenue task force. We have frequently performed the neuroscience symposium. It's been basically usually every 1 or 2 years in the summertime. Unfortunately, because of the pandemic, we've not been able to do that, but we plan to restart that in the near future. We are planning to update our spine program website and again, apply for the advanced spine certification, again, which Maria will discuss in a minute. Next, please. I'm the old guy in the middle there. I've got there's 3 main spine surgeons here in our group. Dr. Kunwar is on the right there. I'm in the middle there, and then Rajiv Saigal, who just joined us about a year ago, is superb, is there as well. We obviously have Dr. Erasmus, who is well loved and well missed in the clinic, but he still has graciously stayed on to help us to continue to obtain this certification, and he's extremely important to us as well. So I'm going to hand it over to Maria, who's going to now talk about the spine certification. Thank you.
Yes. Good evening, everybody. Thank you for inviting me to present today regarding the Advanced Certification in Spine Surgery, acronymed as ACSS. And I'm here to tell you what it entails to achieve this certification. Can we just go back one slide? Thank you, Dr. Eichbaum.
Thank you.
Yes. While we're here, I just wanted to go ahead and set the story of advanced spine certification and our journey into the certification. What is it that sets our organization apart when we have this certification? As we know, degenerative spine disease is the most prevalent and costly disease worldwide, and low back pain is the most common cause of work disability in the US. And in the US alone, the total direct cost for spine care exceeds 100 billion annually. Lumbar spinal fusion surgeries, which range from 60,000 to about 110,000 per procedures, have significantly increased in frequency. So as the patient population ages, the number of spine surgeries in the United States is likely going to increase. And it is probable that our competition will increase as well. The Joint Commission Advanced Certification in Spine Surgery will help elevate our spine program with the evidence-based proof of clinical quality and safety sought by both patients and payers, definitely giving us a leg up on this competition. The certification also shows our commitment to providing an exceptional level of care by upholding to the highest standards and performance measures. We gain verified proof of the quality we deliver across the continuum of care. Next slide, please. Thank you. So the advanced certification in spine surgery gold seal approval, as you see, is awarded to hospitals, critical care access hospitals, and ambulatory surgery centers that perform spine surgeries and meet or exceed the highest level of national performance standards. This certification is awarded by the Joint Commission in collaboration with the, as you can see, American Academy of Orthopedic Surgeons and the American Spine Registry. And it's also a collaborative effort on the American Association of Neurological Surgeons and American Academy of Orthopedic Surgeons. This advanced spine certification is a fairly new certification which went into effect on July 1st, 2021. So far, there have been 13 organizations that have successfully achieved the certification, out of which 12 are primarily on the East Coast. In November last month, 2022, UC San Diego Health became the first healthcare organization in California to receive the certification and currently remains the only one to have achieved it on the West Coast. Next slide, please. So what makes this certification set your program apart?
Cute.
Organizations like Washington Hospital that seek to obtain this advanced certification in spine surgery need to apply evidence-based standards uniformly and consistently. These standards were developed with the input of healthcare professionals, as you can see, providers, experts on the subject matter, and also consumers. And these were reviewed by the AOS. So basically, on the slide over here, you can see that the application on these standards gives us the ability to, firstly, measure results that we derive from surgeon and procedure-specific dashboards. It also helps us to compare national performance benchmarks. It also monitors patient outcomes, which we'll see later on, through a streamlined process. It helps us to qualify for the National Distinction Program, especially with Aetna and some other insurance agencies, which I will discuss in the next slide. Also, certification helps our organization align with our CMS Advanced Bundled Payment for Care Improvement and the Merit-Based Incentive Program. But above all, it improves our patient safety and the value of care delivered. Next slide, please. I wanted to talk briefly on how this advanced certification in spine surgery will help us with Aetna. So Aetna has a quality distinctions for ortho cases called IOQ, Institute of Quality, and has multiple data points for eligibility. The Joint Commission has communicated that in future, Aetna will be requiring the advanced certification in spine surgery in order for organizations to participate in Aetna's IOQ provider list. So this is projected to go into effect in 2024. Next slide, please. So how does the certification benefit our patients? Well, advanced certification in spine surgery provides structure for programs to improve their patient outcomes and reduce patient risk by utilizing, as you can see, standards, best practice guidelines, and enforcing adherence to required performance measures. It helps the healthcare organization to develop consistent communication and collaboration among all healthcare providers involved in the patient's care. And when you see this diagram, it shows that throughout the entire continuum of patient care, advanced certification is focused on ensuring collaboration and communication at every point of care, providing consistency of care at every touch point, right from the outpatient offices into intraoperative and inpatient care, discharge, and follow-up. And this is how our survey will be guided by. Next slide, please. So what is the eligibility criteria? You have three points here. One is the program must have served a minimum number of 200 patients or cases annually. It could be a physical year or it could be a calendar year. And that the program must be an active participant. So you have to be involved, you have to participate in ASR, and you have to use the data collected from this registry to analyze and perform performance improvement plans. And an on-site intraoperative observation will be conducted. So it's a 2-day survey, and it is essential that they will be viewing a case, and they will also be going across the whole continuum of care, right from the doctor's offices into inpatient and follow up on discharge. Next slide, please. So as you may recall earlier on in the presentation, Dr. Aikbaum briefly mentioned that we had 355 cases, but not all cases of that volume qualify for this certification. So the cases that are included in the certification have to meet the inclusion criteria set up by the registry. So what cases are included? The cases that are included in the eligibility criteria are primarily degenerative disorders, while surgeries due to tumors, fractures, or trauma are not eligible and are not included. And that's basically what's depicted. I've depicted here on this inclusion criteria. Your ICD-10 codes and your procedure codes have to be within the inclusion criteria. Next slide, please. So as discussed previously, and I know Dr. Aikbaum said we're also doing this, we're monitoring this, you've seen our data. It is a requirement to collect and report data on these 4 standardized measures, primarily surgical site infection rate, new neurological deficits within 90 days, and unplanned return visits to OR. And also on the prompts, which Dr. Aikbaum did explain that they are general health and spine-specific functional status assessments before and after. And they're in increments, post-operatively, they're in increments of 3 months, 9 months, or 12 months. As you can see on the right-hand side, for fiscal year 2022, we have had 0 cases for surgical site infection and neurological deficit and return to the OR during the same stay, and a 0.5% within 30 days. So we have a very favorable data. Well, the 4th performance measure, that is the prompts, requires collection at different increments. Like I said, at 3 months, 9 months, preoperatively 3 months, 9 months, and a year. So you can well imagine the coordination and the manpower that goes into this data collection. And as you can see, we have 71% completed functional assessments preoperatively, but about 18 postoperatively. So during our gap analysis, we did identify that the PROMS data collection was a challenge. And I will discuss in the following slides the actions and strategies that have been put in place to overcome it. Next slide, please. So how we educated our community on our spine program. However, before we talk about the challenges, I want to take an opportunity to discuss how our team has tried to reach out to people in the community and provide information about our spine surgery program. We've had articles published on spine care in the Tri-City Voice. Dr. Eichbaum has given some lectures and spine talk in the community. We've also had some social media posts highlighting spine patients, and we have online education through our website. We care very much about our patients, and we want them to know about the excellent care they receive here at Washington Hospital. Next slide, please. So in order to roll out this program, we completed a gap analysis, and I want to share some of the strides that we've achieved and some which are in the process of near completion. So the completed ones are the ones that we, when we onboarded with the data registry build, that required participating and signing up with ASR. Our data registry build involved our IT, outpatient and inpatient services all worked together, testing our data, readjusting rejected cases according to the specification, and building a spine dashboard to monitor and track our case requirements of minimum 200 and reviewing our performance measures. We also had to do back work, review the Joint Commission standards, redesign our protocols, order sets, our care pathways, and also educate our staff by putting SABA modules for all disciplines caring for this patient cohort. Present, we've initiated the application process as of now. As you had seen that PROMS data collection was a challenge, we explored the option of utilizing an outside vendor to implement patient engagement platform to help collect the required PROMS data. One of our spine surgeons was familiar and had been utilizing this service through a vendor named CareSense. Therefore, we decided to add the other two surgeons on this platform. And this data will be collected by CareSense at different intervals, preoperatively 3 months, 9 months, and 12 months, and shared with us for reporting, which is mandatory. Moving on, we will be continuing to monitor our volume load and plan for a mock survey in preparation of our certification. Next slide, please. So this is just a little timeline I put together when we started this project. We initiated this project in February of 21, and as you could see, all the build and going back and forth with the registry, we were able to do our first successful submission in August of this year. Currently, we have initiated our Joint Commission application process. And in October of this year, we contracted with our PROMS collection vendor, CareSense, and we will be going live this week. As we move further into the next year, we plan to submit our application tentatively in the first quarter of 2023, with a projected Joint Commission survey date 4 to 5 months thereafter. Next slide, please. Okay, I guess that brings us to the end of the presentation. I sincerely appreciate your attention this evening. Thank you all.
Thank you very much, Maria and Dr. Eichbaum. This is a very exciting program. Very, very interesting to see the progress you're making and the plans that you have ahead of you. This would be a very, very wonderful achievement for the spine program in the hospital. Thank you very much for your work and for the dedication that it takes to achieve this kind of a designation.
Thank you for your support too.
Yeah,
Yeah, thank you for your support. And again, it's a huge team effort.
Yes.
well, we appreciate your leadership, and it'll be very exciting to see this come to pass. Another very, very important program in the hospital. Thank you very, very much. Appreciate
Thank
appreciate your
Thank you.
presentation tonight.
All right. Thank you very much. Have a good night.
But have a good,
You too, you too.
yes. Right,
Well,
thank you.
We'll now move on to our reports. We first have our medical staff report from Dr. Hyder. Dr. Hyder, if you could make your presentation.
Yes. Good evening to all. Thank you so much. First, the medical staff, the active staff is 337 with administrative 1. Advanced practice providers are 38. Ambulatory is 97. Consulting staff is 7. Courtesy staff is 23. Leave of absence is 5. The provisional active is 49. Provisional APP, that is advanced practice providers, are 14, and provisional consulting are 2. Provisional courtesy are 13. Total grand total is 586. And then I want to bring the attention that we always face that census continue to be high, and the staff is always reminded, the doctors and everybody, to discharge the patient early, and they have been cooperating, and the nursing and everybody has been of great help. The other thing is the medical staff is, and especially the gastroenterology, is very grateful to WTMF and Miss Harts for, there was a locum at the time of Thanksgiving, and that service was very appreciated. And there was a luncheon done for the medical staff, holiday luncheon, and this was done last Friday, and it was attended by Miss Harts, which is very much appreciated also. This is my report.
Thank you very much, Dr. Hyder.
Thank you.
We'd now like to move on to our Service League report from Debbie Fury. Is Debbie with us?
You're on mute, Sheila.
I believe Sheila is stepping in for Debbie this evening.
Sorry.
Hello, Dr. Stewart. I was so excited. I didn't unmute myself. So I apologize. I apologize. Debbie is not with us, so I'll be presenting on her behalf. Again, good evening to all of you, to all the members of the district board, and of course, greetings from all of us volunteers. Debbie is out tonight. She cannot be with us, so I will be presenting on her behalf. I have a few numbers and few happenings that I'd like to share with you. So for the month of November, 153 Service League volunteers contributed 1,967 hours to the hospital. We also hosted an orientation in the month of November, which was attended by 56 high school students, 10 college students, and 1 adult, because we need more adults to be involved, but we had plenty of high school students, and we are very, very excited to welcome these junior members, volunteers into our fold. They will be staffing assignments in the hospital lobby, gift shop, and the birthing center. Just after Thanksgiving on Monday, November 28th through Wednesday, November 30th, the Service League hosted the semi-annual $5 jewelry and gift sale. The shopping was awesome and brisk on all 3 days, of course. Why not? The community members and employees picked up some great bargains, perfect for the holiday season and gift giving. I'm also happy to report that the commission earned by the Service League totaled over 9,400. In conjunction with the sale, the Service League also hosted a holiday drawing in the lobby of Washington West, featuring attractive seasonal decorations and furnishings. Another highlight of the November month was the unveiling of a beautiful historical collage created by our local artist, Nancy Pratt. The collage depicts the civic contributions made by the women of the Country Club of Washington Township Women's Club, a group that has been in existence since 1896. The Women's Club was instrumental in founding of the Service League in 1955. The collage now hangs in the Volunteer Services Suite in Washington West. The unveiling was attended by Fremont Mayor Lily May, Vice Mayor Teresa Kang, City Manager Karina Shackelford, and the President of the Washington Township Healthcare District, Jeannie E. And finally, one last thing I'd like to highlight that happened in the month of November, which was very unusual and a sticky situation assignment, special assignment for us, no pun intended. The volunteers assisted in November with 1,600 Rice Krispie treats. That's why I said sticky special assignment. 1,600 Rice Krispie treats for employees to recognize the renewal of the hospital's magnet status. This was one of, by far, really by far, one of the sweetest assignments we have had, we have been given, and we don't mind assembling more of those sweet ones. So we would appreciate if you give us more of that. Anyway, that's my report from the Service League. On behalf of all the members from the Service League, I send you our best wishes for the holidays and a very happy New Year to all of you.
Thank you very much, Sheila. That was a very sweet report.
Oh, thank you, Doctor. I appreciate that, Dr. Stewart.
Thank you very, very much.
Thank you.
We'd like now to move to our lane report. This will be by Matthew Stauffer. Kimberly, could you introduce Matthew for us?
Yes, thank you. It is my pleasure to introduce Matthew Stauffer. He is the manager of the Washington Outpatient Rehabilitation Center. He is treated exclusively in the outpatient setting in Fremont for the past 17 years and has been in clinic management since 2010. Originally from southwestern Pennsylvania, Matthew graduated from the Pennsylvania State University with a Bachelor of Science degree in kinesiology and earned his Doctor of Physical Therapy degree from Slippery Rock University in Pennsylvania. Matthew's first exposure to Washington Hospital came in the form of a 6-month clinical rotation with Dr. Dearborn at the then Center for Joint Restoration, as Matthew has a special interest in post-surgical treatment of total knees and total hips. So I want to welcome Matthew, and he is going to be presenting around the lean concepts that have been used in the Washington Outpatient Surgery Center.
Thank you, Kimberly. I'm going to start sharing my screen. All right, can everybody see that?
Yes.
Excellent. As Kimberly said, my name is Matthew Stauffer, and I'm the manager of the Washington Outpatient Rehab Center, or WORK for short. In January of this year, I had the pleasure of joining WORK. This evening, I was asked to share with all of you some process improvement changes that I've made in the clinic over the past 11 months using principles of lean. For our purposes this evening, I will focus on access to the clinic and capacity within the clinic, and describe efforts made regarding staffing, scheduling, reduction of missed appointments, and the resulting overall patient experience. My first month in the clinic, I performed, not month, but my first morning in the clinic, I performed a thorough walkthrough. There was one thing that was odd to me. There was this whiteboard on the wall in between 2 of the treatment rooms. I have it pictured here. For a time, I had no idea what it was, but later found out it's called a frontline visibility board. This board has become a centerpiece of the office and a vital communication tool that fosters the key principles of lean as indicated. Establish aligned goals, enhance communication, and lastly, identify and remove barriers to achieving goals. The biggest issue this clinic was facing when I started was a 6-week plus wait time for new patient appointments. In addition to this wait time, the clinic's overall utilization rate was a little over 50%. Our goal was to increase access to the clinic and bring our visits per day count closer to 100. Here is a visual representation of the new patient appointment wait time since January. You can see in January, there was a 7-week wait for scheduling evaluations. These wait times from earlier in the year clearly show there was a problem with access to the clinic. Basic lean philosophy takes a complex problem and challenges you to identify components of that problem that will ultimately affect some goal. The clinic had a problem with patient access. Using a cause and effect diagram like the one shown, I was able to break down factors that affect the goal of increasing patient access to the clinic. I focused on improving performance in 3 specific areas: matching staffing levels to scheduled capacity, adjusting the schedule to increase appointment availability, and reducing occurrences of patient no-shows. To enhance the patient experience, I reconnected the therapist to the why of physical therapy. This is the basic framework for how our patients are scheduled. Evaluations are 1 hour, follow-ups are 30 minutes, and a full schedule was 10 to 14 patients per day per therapist. Our standard workflow for the evaluation is straightforward. New patients either receive the self-history via email, consent forms prior to their appointment, or they arrive early to complete them. Once patients are checked in, our aide will room them where vitals are taken, and the patient will wait for the physical therapist. Upon entering the treatment room, our PTs will sanitize their hands and introduce themselves to the patients. The evaluation will take place, findings will be discussed, goals for treatment will be formed, a home exercise program will be developed, handouts created, and reviewed with the patient. The therapist will instruct the patient on the frequency and duration for their treatments. And finally, the therapist will escort the patient to the front desk where they will schedule follow-ups. The therapist then has time to document and provide the billing codes for the treatment. I mentioned that when I started, the wait time for new patient evaluations was greater than 6 weeks, and there was a rather long wait time for follow-up appointments. While this leads to angry patients, angry doctors, and ultimately missed revenue opportunities as patients seek treatment elsewhere. I didn't change our basic scheduling format, but in an effort to reduce wait times, I set aside multiple block holds or appointment holds during the week, so we have the ability to offer a number of same day, next day, or same week appointments. You can see these holds as indicated by the red text in the screen grab shown. With proper staffing, as you will see later, and adjustments to the schedule, the wait times for evaluations are now reduced to 2 weeks or less, and follow-ups occur the same week or within 1 week. Once again, our goal is to have 100 patient visits per day. No-show visits are a major obstacle to our 100 visit per day goal. For our purposes, a no-show visit is a no-call, missed appointment, or same-day canceled appointment. You can see there was a sharp increase in no-show visits between April and May. Site-wide, the hospital has an automated system that patients are able to opt into that calls, texts, or emails appointment reminders. This has always been utilized by our front desk, but it isn't always enough. Starting in May, we took these reminders and brought them down to the provider level. To reduce missed appointments, my therapists began to take time during their treatment session wrap-ups to remind their patients of their next appointment. This face-to-face reminder and confirmation has helped to reduce our no-show missed appointment rate by 3+% in May through October. We saw an uptick in missed appointments last month. During a conversation in one of my weekly meetings, the question came up of why are these appointments missed? So to gain further insight into our no-shows, I began to note and track reasons for these missed appointments. You can see on this chart, number 1 reason, unfortunately, is no reason given, and the second most prevalent reason has been sickness. Last month, the predominant reason for no-show or same-day cancels was illness. The no-show trend and specific reasons for missed appointment sessions will continue to be tracked on a monthly basis. I've indicated the steps taken when a no-show visit occurs. Our approach to same-day cancels is straightforward. If there is enough time, the front desk staff will look to move patients from that day's schedule into the open time slot, or look to bring in someone from later in the week into that opening. If there is a no-show, no-call, the front desk will call the patient. They will inform the patient that they missed their appointment and ask for a reason for the missed visit. They will ask the patient if they could come in later the same day or look for openings the next day if able. If not, the patient will be reminded and advised to come to their next session. If a patient has 3 no-show, no-call appointments in a row, they will have their future appointments removed from the schedule and discharged from treatment. Going back to January, the clinic was operating a little differently and was facing a capacity issue. The clinic was 3 FTEs understaffed and unable to meet the demands for appointments. The clinic's resulting wait time for an evaluation was greater than 6 weeks. The utilization rate at the time was 54%. That month, I was able to hire a full-time PT and a full-time PTA. Within the first month, our utilization rate rose by 18%. I held my first staff meeting at the end of January. I presented clinic metrics that are essential to keep the staff in alignment with our operating goals. It was expressed to me during this meeting that these metrics have never been shared by past clinic management. Around that same time, I learned about the hospital's lean program and team huddles at the clinic's visibility board. These huddles offered an excellent opportunity to communicate efficiently and timely with the clinic staff and raise awareness of any issues that are immediately impacting the clinic. I began to utilize huddles and display certain metrics on our visibility board. This chart, as well as several others in this presentation, are directly off my clinic's visibility board. I have highlighted with arrows specific events that have increased and decreased our average utilization rate over the past 11 months. You can see in January, with the addition of myself and the 2 therapists I hired, our average utilization rate in January through February increased from 49% to 70%. We were able to sustain an average of 70% through March. By June, we were once again 2 full-time therapists short. I was able to hire our former traveling therapist back as a full-time employee in September. I then hired a different traveling therapist to fill the gap for our 1 remaining vacancy. By October, our utilization rate was going up. However, in November, we were hit with multiple therapist illness, as well as patients calling in sick, causing our daily average to reduce. In terms of missed appointments, I began to see a rising trend of no-shows occurring in the clinic beginning in March. This is how our utilization rate compares to last year. In January, our utilization started at its lowest point, being 54%. Within that first month, it rose to 72%. It was maintained through May. Again, this rate is based on our 100 visit per day goal. In June, we were once again 2 FTEs short and our rate dropped. By the end of September and early October, with the addition of 1 FTE and a traveling PT, our rate began to increase again. Our utilization rate will continue to be tracked on a monthly basis. Earlier, I described the therapist's standard workflow. The final responsibility of the therapist in our workflow is to apply CPT codes to the evaluations and treatments that are provided. I would like to touch on the mindset changes that were made to our CPT coding over the past 11 months. In January, at my first staff meeting, I introduced CPT codes that were more diversified and better descriptors of the intent of each PT session. As physical therapists, our number 1 goal is to restore function in our patients. We do this through a combination of education, manual treatment, and prescriptive exercises. I reminded the therapists that to truly put our patients first, we need to address the why for treatments we provide. My favorite example of a why is that of a grandparent who seeks out treatment to be able to pick up their grandchild. This action can be broken into many parts. One part is doing a squat. Well, if we have this patient perform a squat just to get stronger at a squat, this is coded differently than having the patient perform squats with the intent of picking up a grandchild. I asked the therapist to reflect on the whys or functional goals for their treatment sessions and provided them case study examples that showed how intensive exercise plays a role in coding. In short, as therapists, we tailor each treatment session to meet the ultimate goals of the patient. I educated the therapists on the use of more specific CPT codes and the rationale behind their use. By doing so, documentation improved, goal writing improved, billing diversity was improved, but ultimately the patient experience became more personal. Everything we do in the clinic is for the benefit of our patients. Well, what do our patients have to say about us? All our patients are provided with a survey following their first session. The survey rubric consists of 8 categories, asking for a rating on scheduling, friendliness, explanation of session length, explanation of procedures, observed hand washing, cleanliness of office, and their overall satisfaction. Looking at the bar graph, the black column are survey results from January, and the yellow columns represent results from November. You can see our largest jump is in cleanliness. This is very likely due to our clinic refresh that happened in August. We had the clinic repainted, and our patients really responded well to it. I'm proud to say that we have scored 95% or above in all categories, and by November reached a 99% overall satisfaction rating. We are getting about a 25% return rate on our surveys. Now the clinic looks like this. We have 5 full-time physical therapists and 1 traveling PT, 1 full-time occupational therapist, 2 full-time physical therapist assistants, 1 per diem pelvic floor therapist, 3 front desk staff, and 1 clinic aide. We offer a full array of equipment, all in a 6,000 square foot space with 6 private treatment rooms. Over the course of my first year here at Washington Hospital, I've learned and embraced several aspects of the lean process. I've been able to align my way of doing things with some of these principles. I have learned the importance of using the daily management system or visibility board to enhance communication with staff, establish and align our clinic goals, and ultimately use it as a tool to identify and remove barriers to achieving our goals. We will continue to address clinic access and capacity on a daily basis. Thank you to John Boyko, Walter Chodo, Don Pipkin, and Tina Nunez for their support, and to all of you for the opportunity to share some of the changes and ongoing efforts that I'm making in the clinic. If anyone has a desire to see the clinic or has questions, I've included my contact information on the slide. Thank you.
Matthew, thank you very, very much. It's wonderful to hear that kind of progress in the clinic, rehabilitation clinic. That's great, great progress.
Thank you.
I'm particularly excited about the wait times and the increase in patient access.
Oh, it's huge. It's a difference maker.
Oh, it's absolutely, you're absolutely correct in that, because in the present environment, patients will seek other care very quickly.
Very quickly.
And we appreciate all you're doing there to tighten that up. And love seeing your reports and how well you're moving along on that. Thank you. Thank you for your presentation tonight. Any other board members have any questions or comments? Again, thank you, Matthew. It was very impressive.
You're welcome.
We'll now move to our quality report. You'll hear that from Carmen Aquilli. I think all of us are very familiar with Carmen. She's a good friend and longtime reporter to the board of directors. Carmen, it's wonderful to see you. Welcome.
Hi, Dr. Aquilli. Why don't I just do a quick introduction? As Dr. Stewart said, I think all of you, many of us all know Dr. Aquilli, and she frequently presents to the board. And as we know, she began practicing medicine in Fremont since the early 1990s. In 2008, she became the director of the intensivist program for critical care. She is board certified in internal medicine and critical care, and she's a fellow of the American College of Chest Surgeons and a member of the Society of Critical Care. She is currently the medical director of the critical care and intermediate care units and is the interim medical director of the palliative care program at Washington Hospital, which began in 2016. And so this evening, she's going to give us a report on the palliative care program. Thank you, Dr. Aquilli, for joining us.
Okay, good evening, everybody. So I know you already know about palliative care, but for those that doesn't know, it's the specialized medical care for people living with serious illnesses or life-limiting illnesses. As an ICU intensivist care, we take care of critically ill patients. And in palliative care, we take care of the seriously ill patient or those with life-limiting illness. So I just want to expand my knowledge and help the palliative care service grow because I really feel that it's needed by the community. So the important message I want to share with you is that palliative care is not about dying, but it's about living well with your serious illness. Most of our patients does not know palliative care. And some of our doctors also think that it's just end of life, but we know it's not. Next slide, please. So the mission of Washington Hospital Palliative Care is to maintain the quality of life for patients with life-limiting illness. It provides compassionate care and relief from the symptoms and stress of serious illness through an extra layer of support for patients and families. It is available for patients at any stage of any serious illness. If you look at the illustration or the graph, you'll see that it starts upon the diagnosis. You can get palliative care, and all throughout before hospice, which is the 6 months before death. So we can be involved on the first diagnosis, during the exacerbations and remission of the serious illness, and even at the end. It will not replace your medical team, but rather work with them as an extra layer of support. It works well with the multidisciplinary team of a physician, that's me for now, but it's improving, nurse practitioner, a social worker also, and spiritual care coordinator. Next, please. So historically, in 2006, the End of Life Task Force, including me, went to UCSF to learn more about palliative care. And then I started doing palliative care rounds in our ICU, where we discuss goals of care with families and, of course, patients. And then in 2015 to 2020, PRIME, which is Public Hospital Redesign and Incentives in Medical Care, have this 5-year plan to develop and support the growth of the inpatient palliative care service. So we got a grant, and in 2016, we went live with the inpatient palliative care program, where a team was established. Also during that time, we were using UCSF Palliative Care Leadership and also the Center for Palliative Care for our own learning. And for our database, we use the Palliative Care Quality Network. Then in 2018, the Stupski Foundation gave us a grant awarded through the WTMF to support now the outpatient clinic. So in 2020, we softly opened the outpatient Danielson Clinic. We went live, started seeing patients. And in 2021, there was a transition of the PCQN to PCQC, which is a more robust and more widespread nationwide network of palliative care practitioners and also database collection. We also started billing for nurse practitioner services. So now in 2022, we're now expanding our program and have more additional, now a full-time palliative care doctor. You know, I'm just interim and I'm just doing this part-time, but I love it because it takes care of the seriously ill patients. And now we're gonna also get approved for another nurse practitioner who is gonna help us in the outpatient and inpatient practice. Thank you very much. And we are also doing work with integration with Epic of our PCQC validation. And we're continually billing, learning more about billing for our NP services. Next slide, please. So for the inpatient program, there's a 13% increase in our volume of palliative care consults from 2021 to 2022. Next slide. So we saw about 426 patients all in all. Average year is about 78 years old. 48% are male, so that's 52% female then. And in the inpatient unit, most of our referrals are coming from 39% from med oncology floor. Medical is about 31%. Then the telemetry, IMC, and ICU are just in the less teens. Next slide, please. So most of the patients, the diagnosis is 24% are cancer. Secondarily is the pulmonary, 13.3%, and cardiovascular around 11.8%. Next slide. So this is our performance outcome. We try to measure the advanced healthcare directives and POLS filing, hospice referral, our length of stay, and patient experience. Next slide. Before that, is there another slide? Okay. So, okay, our next slide is about advanced healthcare directive and POLS, which is the physician order for life-sustaining treatment. I think this is very important for the public or patients to know. What is an advanced healthcare directive? It is a form that allows patients to choose who they want to speak for them regarding their healthcare and provide a general guide for their healthcare choices. And another form is the POLS, which specifically describes the medical treatment that the patient wants towards the end of their lives. So these are for the seriously ill patient. It gives patients more control over their treatment and can help reduce patient and family suffering. It is a signed medical order, and specifically, of course, for the life-limiting illness. And it specifies the exact wishes about medical treatments. So the healthcare directive is also like that. But the thing is, advanced health directive is done by the patient or person that's still mentally intact, so that they can assign who's going to be their surrogate decision maker. In the POLS, this can be done by the patient themselves or their surrogate decision maker, and it's signed by the doctor. So next slide, please. So on the left side is the California Advanced Healthcare Directive. It has 3 parts. The part 1 is choose your medical decision maker. It gives you 2 or 3 options to choose your first agent, the second agent. The second part is make your own healthcare decision. Like, what do you want? What is the most important thing in your life? Quality of life and all those kinds of things. And the last one is to sign the form, and you have to have 2 witnesses. One is a blood relative and one is not. So that's the advanced healthcare directive. Is done by a person who is still conscious and know what he's talking about. When you become demented and you did not have a surrogate decision maker, the next of kin or whoever is assigned to be your decision maker can also help fill up the physician order for life-sustaining treatment. It has 3 parts. A is to choose whether you want cardiopulmonary resuscitation. B is what medical intervention do you want? So it's more specific. Do you want full treatment with resuscitation, CPR, putting the tube in? Do you want just selective treatment? So you just want maybe IV antibiotics, you don't want to be resuscitated anymore, you don't want treatment, or you just want comfort-focused treatment, which is not having active treatment, but the focus is more on your comfort, on your pain and suffering. The C part is artificial administration of nutrition. Some of us would not want any artificial nutrition. Some of us would have a trial period for artificial nutrition, and some of us wants long-term nutrition, whatever happens. And the D part is the information and signature. So where did you get the information? You are the assigned healthcare worker here, and then the doctor or the nurse practitioner or physician assistant can sign with the patient or the representative at the very bottom. So that's the importance of the 2 forms. And those are the things we discuss on the first or the second visit, because most of our patients does not want to face this, does not want to have these forms done. So those are the difficult conversations we do in palliative care. Next slide, please. So among our patients in 2022, 3 out of 4 patients filed an advanced healthcare directive or POLS during their hospital stay. About 53% we were able to get them to do the POLS, and about 25% the advanced healthcare directive. Next slide, please. So the patients that were consulted, around 26% of them expired during their hospital stay. 23% went home with home health services. So there are, these patients we have are the sickest patients, the seriously ill patients, aside from the critical care. 22% we were able to refer to hospice, and 20% went to skilled nursing facility. Only 4% we went home on their own self-care. Next slide, please. So in terms of patient experience, 100% of these eligible palliative care patients were called within 3 weeks after discharge. 35% responded to the survey. And on the average, they rated our palliative care service very good or excellent. Number 4 is very good, and number 5 is excellent. Next slide, please. So now we will go to the outpatient world. We also had an increase in palliative care referrals in the outpatient from FY21 to 2022. Next slide. So about 88% of them completed their visit, some canceled, and some did not show, but it's a lot better than 2021. Next slide, please. Again, the demographics. The ages are between 70 to 71. Male is less than female, only 46%. In terms of race, most 57% are Asians. And our referral source are mostly from oncology, about 46%. General surgery also gave us 16%. And the primary ambulatory is 11% and inpatient. So these are all important to us, so we know where else can we get our consults. Next slide. So the most common serious illnesses leading to consultation is 78% cancer, around 11% the same, cardiovascular and dementia. So you'll notice that in the outpatient, we have more dementia patients, but most of them, inpatient and outpatient, are all cancer patients. Next slide, please. Next slide. So what are the outcomes? These are the things that I discuss when a patient comes in. Mostly all of them, we discuss their spiritual care needs because those are important, not just only the medical, but we discuss the non-medical part. You know, if religion is important to them, their psychosocial needs, you know, some of them, they don't have any transportation, so we send them for transportation, Meals on Wheels, or they need a social worker or caregiver list. Most of them we discuss their advanced healthcare directive. And the difference between outpatient and inpatient is I have mostly more patients with symptom management, you know, those that come for pain, mostly cancer pains, because I don't take care of non-cancer pain. So this is the difference between the patients I see in the inpatient and outpatients. I do more of that. And then we also did some hospice education and also gave them a lot about caregiver lists. And one interesting patient I have is wanted information about death with dignity patient care. So I learned more about that too. Next slide, please. So out of the 39 patients that I saw, within 30 days, there were 28 that were not admitted to the inpatient, which is important. There were 11 that got admitted within 30 days. And when we drill down, mostly due to infection, which you can't really, you know, take care of, is in the outpatient. Intestinal obstruction, colon cancer with intestinal obstruction needs IV hydration. So we will continue to monitor this. Next slide, please. So our next step is to encourage all clinicians to refer hopefully earlier from admission in the inpatient. Establish really our multidisciplinary team, a full-time MD, full-time 2 NPs. We still need a palliative care social worker and our spiritual care coordinator, because it's a lot better to do it as a team. One will be discussing the psychosocial, I will be taking care of the symptom management, and then all together we can address the issue of that patient as a whole. And of course, we want to increase our follow-up too. Next slide. Yes, that's it. I hope you learned something, and thank you very much, Board of Directors and everybody for listening to this talk. Any questions?
Thank you, Dr. Aquilini. I feel like you are meeting such a very tender niche of patients. Family members often don't know what to do when they're kind of in between. And I see you meeting a really important need there in our community. So thank you for that. I do have one question about Pulse. Is it still valid if the MD who signed it is no longer practicing?
Yeah, it is a licensed practitioner at that time when they practice.
Okay,
I mean,
okay.
when they were doing it, And
Okay.
also, I forgot to say, all these forms can be changed. They can change their mind and say, oh, I don't want full code anymore. I want DNR, DNI, or the other way around. They
Okay.
can change that. So we always ask them every admission or every visit, we always ask them if there's any change in their documents. But yes, if it's a valid practitioner at the time of their practice, it's still okay.
Okay, that's helpful. Thank you so much.
Thank you, Carmen. It is.
Thank you for listening to a serious problem.
It's
Hopefully
always
it did not, depress you guys. Thank you.
No, I don't think it's depressing. I think it's very encouraging that we're addressing this critical need. I personally, I've experienced that with my parents and my wife's parents and some friends even. I have a good friend that's on hospice care right now. And it is a very, very tender, very difficult time for everybody. And it is wonderful to see that need addressed. And it's also wonderful to see you. What a pleasure, pleasure to see you, Carmen. And we appreciate you.
Thank you all very much.
We'll now move to our finance report from Chris Henry, our Vice President and Chief Financial Officer of the hospital.
Thank you, Dr. Stewart. Tonight we will be looking at Washington Hospital's operating indicators and financial results for October. Average inpatient average daily census for the month came in higher than budget by 4.5 and 150.1. Our combined average daily census, which includes our outpatient observation stays, came in 1.7 above budget at 158.5. Admissions for the month were 13% higher than budget at 912. And our patient days were 3.1% higher than budget at 4,654. Outpatient observation equivalent days for the month were 86 lower than budget at 260. And our average length of stay, as you might have guessed by the patient days, came in lower than budget at 5.2. And, again, that's an indication of a lot of work that's been done in the house. Moving into utilization, the case mix index for the month, which is an indicator of the severity of the cases that we saw, came in at 1.53. We had expected more acute patients at 1.6 in the budget. Deliveries for the month were 3 below budget at 122. We had 9 more surgical cases than we had budgeted for at 371. Cath lab cases, again, below budget by 43 at 177. And that, again, is a result of the physician turnover we've been dealing with. Outpatient visits for the month were 145 higher than the budget at 9,140, and that favorable variance driven largely by cardiac rehab and x-ray. Emergency room, again, exceeding their budget by 305 visits at 4,970. Here's a look at the activity in both the ORs and the cath lab. In the OR, our joint replacement cases and neurosurgical cases came in lower than budget. Cardiac surgeries were right on budget for the month, and our other category higher than budget by 24 at 185 cases. In the cath lab, really lower across all service lines. So again, as we continue to add physicians, we're hoping to see that volume come up. Looking at productivity, our productive FTEs for the month were 65.1 higher than budget at 1,434.7. Our non-productive FTEs lower than budget by 12.7 at 151.6. So our total FTEs for October came in 52.4 higher than the budget at 1,586.3. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in a little bit higher than budget at 6.41. We had expected 6.23 for the month. Moving into the financials, total patient revenue for October came in about $1.4 million lower than budget at $191,712,000. Our total deductions as a percentage of revenue came in almost right on budget, just slightly lower at 76.82%. And looking at the details there, the payer mix was pretty balanced in the month. So both our contractuals for our patients that are sponsored by insurance came in almost right on budget as a percentage of revenue. Our private pay was a little bit lower than budget as a percentage of revenue, so their contractuals were a little bit lighter than we had expected at budget at 1.88% versus 1.91 in the budget. So we ended the month with net revenue of about $207,000 lower than budget at $44,982,000. Operating expenses came in $1.7 million higher than budget at $44,229,000. That variance largely driven by our salaries and wages with our higher FTEs. About $1.5 million variance in salaries and wages. We are still seeing a lot of use of agency personnel because it's just really difficult to find people out there. Benefits were higher than budget by $389,000, driven by a higher volume of health and welfare claims in the month. And then our insurance, utilities, and other category lower than budget by about $189,000. So we end the month of October with an operating bottom line of $753,000 against a budget of almost $2.7 million. And again, revenue variance really being driven in the cath lab. Oh, sorry, I got to finish up with that one. Non-operating income for the month came in with a loss of $349,000. Again, largely driven by an unrealized loss on our investments of just under $500,000, and a total bottom line for the hospital of $404,000 in October against a budget of $2.7 million. Looking at our financial accounting standards board presentation, and this is a representation of how the financial markets might adjust our financials when they look at them. First thing they would do is reclassify our revenue bond interest out of the non-operating category and up into operating expenses. So we end up with that was about $538,000 in the month. We end up with operating expenses of $44,767,000 after they're adjusted, and an operating bottom line of $215,000. Next thing they would do is eliminate our general obligation bond interest expense, the tax revenue that supports the debt service on those bonds, and our unrealized loss on investments. FASB doesn't recognize those items. So we end up with non-operating income for October from a FASB perspective at $322,000 against a budget of $333,000, and net income from a FASB perspective of $537,000 against a budget of $2,372,000. quick look at earnings before interest, taxes, depreciation, and amortization, and this helps us understand what kind of income the operations and non-operating activities are providing to the institution. The first thing we do is we pull our depreciation expense out of our operating expenses, as that's a non-cash item. And we end up with EBITDA of $5.7 million from our operations. We then go down into the non-operating section of our income statement and look at our activity there before recognizing interest expense. That number for the month was $1,350,000. So combined, about $5.7 million generated by Washington Hospital's operating and non-operating activities to fund debt service, capital expenditures, and future program development. So are there any questions on October? Okay.
All right. I will go ahead and present the preliminary operations report for November 2022. As Dr. Hyder mentioned, we have been seeing an increase in our census, and that definitely started in November and has continued into December. So looking at our preliminary gross revenue of $198.4 million for November was above the budget by $9.2 million or 4.9%. and was above November of 2021 by $16.8 million or 9.2%. Inpatient gross revenue of $120.2 million was above budget by $9.9 million or 9%, and $18.1 million or 17.7% above November of 2021. Room and board, inpatient surgical services, and inpatient ancillary services revenue were all above budget, but the inpatient cath lab revenue was below budget. Our outpatient gross revenue of $78.1 million was below budget by $700,000 or 0.9%, and $1.4 million or 1.7% below November of 2021. And really, the outpatient cath lab and outpatient observation revenues were both below budget. In November, there were 57 adult COVID-19 discharges, representing 6% of total discharges. This was an increase of 22 cases from the prior month, and was 44 more than November of 2021 at 13 discharges. I do want to note that in November, there were also 17 flu cases and 23 RSV discharges, representing 4.3% of the total discharges. Looking at our key census statistics, the average length of stay of 5.02 was below the budget of 5.59 by 0.57 or 10.2%. This was also lower than the November 2021 average length of stay of 5.43. There were 11 discharges with length of stay greater than 30 days, ranging from 34 to 94 days. Excluding these outliers, the average length of stay was 4.76. So still in-house at the end of the month, we had 5 patients with lengths of stay over 30 days. They range from 31 days to 65 days. Our outpatient observation days at 241 were below the budget of 350 by 109 days or 31.1%, and 110 days or 31.3% below November of 2021. As I've mentioned in the past, the new portal of entry program is resulting in decisions regarding patient placement being made more quickly upon admit or discharge, so patients are spending less time in observation. Our inpatient daily census of 163.7 was above the budget of 147.1 by 16.6 or 11.3%, and above November of 2021 average daily census of 136.9. So the combined average daily census of 171.7 was above the budget of 158.8 by 12.9 or 8.1%, and 23.1 or 15.5% above the November 2021 average daily census. Moving on to admissions. Admissions of 969 were above the budget of 789 by 180 or 22.8%. November 2022 admissions were 229 or 30.9% above November of 2021. Our patient days of 4,910 were above the budget by by 496 or 11.2%, and were 803 days or 19.6% above November of 2021. We saw adult med surge days that were higher than budget by 341 days. Our OB peds NICU days were higher than budget by 176 days. Our intermediate care unit days were higher than budget by 18 days. Our one area that was below the budget was the ICU days, and they were lower than budget by 39 days. Also, we're busy in terms of our surgery volume. Our total surgeries in November of 385 were above budget by 17 or 4.6%. Surgeries were 5 or 1.3% above November of 2021. Our inpatient surgeries at 143 were 16 or 12.6% above budget, and our outpatient surgeries at 242 were 1 or 0.4% above budget. Looking at the breakdown of our surgical activity, joint replacement surgeries were very busy. We were above budget by 21 or 13.6%, and we're 9 or 5.4% above November of 2021. I do just want to note, as I've said in the past, the Peninsula Surgery Center did start billing for Medicare in October, at the beginning of October. We did secure contracts with Aetna and United Health that went into effect in October, but we are still in the process of negotiating with the other payers. I will say that we did have 48 cases that were done in Peninsula Surgery Center in November. Moving on to neurosurgery, or neurosurgical cases were below budget by 2 or 6.9%, but they were 6 or 28.6% above November of 2021. Our cardiac surgical cases were below budget by 4 or 28.6%, and were 3 below November of 2021. Then all other surgical cases combined were above budget by 2 or 1.2%, but 7 or 3.9% below November of 2021. Moving on to our cath lab, we continue to have some challenges in our volume in cath lab. For November, they were at 181, which were 35 or 16.2% below the budget of 216, and 2 or 1.1% below November of 2021. Cath lab inpatient cases at 105 were 6 or 5.4% below the budget of 111, but 19 or 22.1% above November of 2021. Our cath lab outpatient cases at 76 were 29 or 27.6% below the budget of 105, and 21 or 21.6% below November of 2021. We are working with our physicians and looking at ways to build back that volume in the cath lab. Looking at the breakdown of the cath lab activity, cardiac cases were above budget by 18 or 19.1%, and 43.6% above November of 2021. Our non-vascular interventional radiology cases were below budget by 25 or 38.5%, and 28.6% below November of 2021. Peripheral vascular cases were below budget by 24 or 48%, and 45.8% below November of 2021. And lastly, our neurointerventional radiology cases were below budget by 4 or 57.1%, but 2 above November of 2021. We had a very busy month for deliveries. Deliveries for November of 145 were above budget by 24 or 19.8%, and 26.1% above November of 2021. I will say this is the highest number of deliveries in a month since December of 2020. So, moving on to non-emergency room outpatient trend, these visits of 8,560 were below budget by 349 or 2.8%, but above the budget, but above November of 2021 by 67 or 0.8%. Let's see, this was primarily driven by lab visits, were 159 lower than budget, or 4.1%, and imaging visits were 168 lower than budget, which is 9.4%. and especially in imaging, we did have some staffing constraints in ultrasound and some issues with our nuclear medicine equipment at that time too. Emergency room visit trends. Emergency room visits of 5,126 were above the budget by 543 or 11.8%, and 885 or 20.9% above the prior year. Looking at our gross revenue recap, surgical cases were above budget by 17 cases or 4.6%, and revenue was above budget by 2.8 million or 7.6%. Inpatient surgeries were higher than budget, while outpatient surgeries were the same as the budget. Our room and board revenue was above budget by 2.2 million or 6.1%. Patient days, as mentioned, were higher than budget by 11.2%. However, our ICU patient days were lower than budget by 39 days or 7.7%. Deliveries were above budget by 24 or 19.8%, driving our revenue above budget by 618,000 or 17.9%. Our emergency visits were above budget by 543 or 11.8%, and revenue was above budget by 803,000 or 6.7%. We did see a higher percentage of lower acuity visits than expected, which drove down the revenue a little bit. Our cath lab cases were below budget by 35 or 16.2%, and revenue was 3.1 million or 23.6% lower than budget. And lastly, our ancillary services revenue was above the budget by 6 million or 6.8%, and this was primarily driven by the inpatient activity. Moving on to our payer mix, government-sponsored patient revenue made up 70.2% of total gross revenue. This was lower than the budget of 71.4% and lower than the prior year's percentage of 70.7%. Our HMO was at 2.5% of gross revenue, just slightly below the budget of 2.6% and lower than the prior year's percentage of 3.1% of gross revenue. PPO was 25.4% of gross revenue, which was above the budget of 24.4% and also higher than the prior year's percentage of 25.1%. Lastly, our private pay was 1.9% of gross revenue, which was above the budget of 1.6% and higher than the prior percentage of 1.1% of gross revenue. Moving on to productivity indicators. You can see our productive FTEs were actually below budget by 7.4 or 0.5% at 1,364.7. Our non-productive FTEs were above the budget by 40 or 19.6% at 244.5 FTEs. We are starting to see some of our staff take the supplemental sick COVID leave again, and we had 15.6 FTEs of this. And this was higher than October, which was at 5.9 FTEs, and September at 10 FTEs. So our total FTEs of 1,609.2 were above the budget by 32.6 or 2.1%. Looking at our FTEs, our productive FTEs per adjusted occupied bed, they came in at 5.05, which was lower than the budget of 5.44 by 7.2% or 0.39, and lower than the prior year of 5.28 by 4.4%. Looking at total FTEs per adjusted occupied bed of 5.96 was also lower than the budget of 6.25 by 4.6% or 0.29, and lower than the prior year of 6.18 by 3.6%. All right, moving on to our outpatient statistics. Our Whitman clinic visits were above budget in November by 501 or 2.9% at 17,861, and 21.6% visits were below of November 2021. There were 2,501 vaccine clinic visits, so our vaccine clinic was very busy in November versus a budget of 1,200 visits. This was the main driver of the favorable variance to the budget. It was offset by lower clinic visits in cardiology, neurosurgery, and neurology due to some open physician positions, and also some of our providers took some time off. Moving on to the DevCo outpatient visits of 2,338, they were above budget by 25 or 1.1% for November. Work volume was below budget by 135 visits or 9.7%. I think as you had seen what Matthew Stauffer presented, they did have multiple people were out sick and on during the month of November. Our radiation oncology center have been very busy. They were above budget by 164 or 48%. WASP visits were below budget by 59 or 11.3%. We did have 3 of our busy physicians that took some time off during November. As mentioned before, Peninsula Surgery Center was below budget by 2 at 48 procedures for the month. And our Ohlone College Student Health Center visits were above budget by 57 or 475%. Moving on to our key financial statistics, days cash on hand for November ended at 154 days. It is a decrease of 1 day from prior month and is 11 days lower than the same period in the prior year. The main reason for the decrease in days cash is due to the higher operating expenses of $5.3 million or 4 days resulting from a three pay periods in the month of November. This was offset by strong collections of $46 million also for November. Then moving down to our days in accounts receivable, they were at 61.6. This is higher than the prior month by 0.1 days and 7.9 days lower than November of 2021. And really the major driver is that during the month, most of the insurance companies were closed for either part or most of them were actually closed for that full week of Thanksgiving. And lastly, there were $439,000 in charity care adjustments in November of 2022. All right, so that was the preliminary statistics for November. Are there any questions?
Good. Thank you very much, Kimberly and Chris. Kimberly, are there any announcements?
Yes, I do have a few announcements. I want to begin with our December Employee of the Month. It's Chris Burko as a unit clerk in maternal and child health. With a mom as an OB technician, Chris Burko grew up learning about Washington Hospital. When he entered the world of finance, he had no idea that years later, he would join the Washington Hospital staff as a unit clerk in the birthing center. Chris's financial background factored into a recent project. During this last year, Chris partnered with nursing leadership in the finance department to review uncaptured charges. This required careful review of patient charts to compare items used with items charged. He was able to identify missed opportunities pertaining to charge capture and help streamline the workflow for maternal and child health. He recently finished cross-training several of the unit clerks to also perform charge capture entry. In addition to this significant financial contribution to the organization, Chris has a positive impact on our patients. As the unit clerk, he has contact with patients from 32 weeks before delivery to their actual delivery date. This means he interacts with moms-to-be for testing and also during labor. Chris firmly believes that working in healthcare means that you put aside any personal challenges you may be experiencing to provide for our patients. He says, the patient-first ethic, that's why I'm here. Outside of work, Chris takes pride in coaching girls basketball at Granada High School in Livermore. Like his work at the hospital, his recreation is also a way to give back and to be a positive force in this community. So we're excited to have Chris Burko as the December Employee of the Month. And now I'd like to just give some updates in terms of health promotion and community outreach and what has been going on. I want to start with those over this last month. We had in November 9th, Ryan Cross in respiratory therapy gave some education on managing asthma, and he did that on Facebook Live and YouTube, and we had 54 live views and 492 people accessed that later. On November 12th, very excited about this. The Athena Project, it's a mural painting depicting the many nationalities living in the healthcare district. And why don't you turn so we can see it? I want to talk a little bit about the Athena Project. And it is, it's a high school student-led 501c3 nonprofit organization co-founded by 2 local students. The group aims to encourage creativity within the local and international communities through education and engagement. Locally, the Athena Project is hosting communal art projects to make an impact in the local art community. And they approached us and wanted to do a mural that was designed specifically for Washington that many students were involved in, and aims to celebrate the diversity of the community we serve. And they wanted to, it's a project, and the artist's response is to hate and hate-related crimes dividing communities. The project's focus is to celebrate the diversity of the community served by Washington Hospital Healthcare System. The mural is designed, is a design concept that was influenced by artists from the Netherlands, Malaysia, and the United States. And students from various local high schools helped to bring the final mural sketch to reality. And you can see it if you drive by on Civic Center Drive, and it's between the Morris Hyman Critical Care Pavilion and the old emergency room. So I have everybody, hope that everybody can go by and take a look at it. It really was something, and very proud of, the students were very proud of all that they accomplished with that. So moving on November 15th, Elisa Curry did education on fall prevention and recovery at the Fremont Hills Retirement Community. We had 10 residents that attended. November 18th, of Washington Sports Medicine covered the Special Olympics, junior high and high school soccer at American High School, and they had 265 athletes that participated. On November 21st, we did a food drive, and they collected 7 barrels of food for the Newark League of Volunteers. November 22nd, Dr. Mustafa, a cardiologist, did education on heart attack prevention at Acacia Creek. 34 residents attended. He also did on December 1st, educational session, Happy Heart Treatment Options for Aortic Stenosis. And he did this on Facebook Live and YouTube. We had 118 live views and 462 people that accessed it later. December 3rd, we hosted a tattoo removal clinic with 32 individuals that attended. December 5th, Dr. Jet Liu, orthopedic surgeon, did education on common foot and ankle problems at Acacia Creek. We had 25 residents that attended. December 8th, Dr. Prasad Kata, endocrinologist, did education on diabetes, understanding and controlling complications, and did that on Facebook Live. And you can see we had 245 live views and 174 individuals accessed it later. On December 9th, we hosted a facility tour for the Future Health Professionals Club of American High School, and we had 35 students that attended. And then lastly, WEO has been busy. They did a drive warmth to benefit the Viola Blythe Community Center in Newark, and they got 12 barrels of coats and blankets and socks collected. So that was wonderful. I do want to say our vaccination clinic has provided over 97,487 vaccine doses, has given 39 MPX vaccinations, and also in November did 375 community flu vaccinations. As you can see, we do have some upcoming health promotion and community outreach events. Starting on December 15th, Wahia Khan, she's talking about self-care and self-compassion, keys to well-being on Facebook Live and YouTube. December 19th, Maria Nunez, as we know, she's the clinical manager of stroke program. She's going to talk about stroke awareness both on the 19th and on January 10th. On the 19th, she's going to be at Cozier Retirement Community, and then on January 10th at Vintage Courts Retirement Community. And then on December 20th, Dr. Asuko, our vascular surgeon, is going to talk about lower extremity edema at Fremont Hills Retirement Community. And lastly, I just want to talk a little bit about the Washington Hospital Healthcare Foundation. And the foundation hosted a community tree lighting event on Wednesday, December 7th in Washington West. Over 200 children and their families attended the celebration, which included an opportunity to take photos with Santa and Mrs. Claus and have refreshments. The musical entertainment was provided by James Logan High School jazz singers and choir, and they did a wonderful job. And also had a performance by the California School of the Deaf, which performed Christmas carols in sign language for the audience. So I think it was a enjoyable time by all. So, and that is my report this evening.
Thank you very much, Kimberly. I am not aware, do we have need for a closed session this evening?
Yes, Dr. Stewart, we do have a need for a closed session, so I would like to do one.
Thank you very much. Then we will adjourn to a closed session with the understanding that any items discussed in that closed session that are appropriate for to report on will be reported upon after the closed session. And that will be available through our television program later on. So we will now adjourn to a closed session.